We will be doing our presentation on shoulder labral tears. SLAP lesions are the most common labral abnormality, and those stand for superior labral anterior posterior tear, and there's an abnormality with the superior labrum, which is centered on the attachment of the long head of the biceps tendon. There's two common causes, which could be microtrauma or direct trauma. Direct trauma could be something like foosh, which is fall on outstretched hand, or microtrauma, which can be repetitive overhead motions. Another type of labral tear is called a Bankart lesion, which is where you detach the labrum from the anterior inferior portion of the glenoid fossa. And then lesions lead to shoulder pain and instability, and there's an internal rotation deficit greater than 25 degrees is correlated with increased risk of SLAP lesions.
So diagnosis of a shoulder labral tear is usually pretty difficult clinically without an arthroscopy. Diagnosis is tough due to the frequent association of other shoulder injuries with SLAP lesions. Imaging plays a really important role, especially MRIs, when you're trying to diagnose. There are 4 different types of SLAP lesions that can occur. The first one, type 1, that you can see on the top right, it's fraying and degeneration of the edge of the superior labrum. This is not often repaired, but it's painful for the patient to horizontally abduct or externally rotate with their forearm pronated. The second time, which is the most common, which is the bottom left, is characterized by the detachment of the labrum and the biceps tendon anchor. It causes instability of the biceps labral anchor. Types 3 and 4 are most commonly surgically repaired. So type 3 it's a vertical tear of the labrum. This is often called a bucket handle tear of the labrum. The remaining portions of the labrum and the biceps actually stay intact. Type 4 is a bucket handle tear of the labrum that extends into the long head of the biceps tendon. On the next slide, we'll have this in writing.
So patients with SLAP lesions usually will have referral pain patterns where pain is felt in the front, back, or side of the shoulder, which can radiate into the upper arm, upper back, or neck. Most often their pain is with overhead and cross-body motions, and symptoms can include popping, clicking, catching, weakness, stiffness, locking, and instability. They're most likely going to show decreased shoulder strength and range of motion, and they usually have pain with lifting objects as well. In a physical exam, most likely the clinical history of the patient could include traction injury, a direct trauma, fall on outstretched hand, chronic anterior and posterior instability, and usually there's no previous injury reported. Some findings you might have in the exam could be increased shoulder laxity, and positive findings with pain provocation shoulder tests being the O'Brien's test, biceps load test 2, sulca sign test, compression rotation test. SLAP lesions are also associated usually with intra-articular disease, partial or full rotator cuff tears, a Bankart lesion, and glenohumeral chondromalacia.
Now we're going to talk a little bit about the treatments for a SLAP lesion. Conservative treatment is usually unsuccessful and leads to surgery. Arthroscopy is the mainstay for treatment. So the stability of the biceps anchor is assessed, and if it's unstable, it's repaired. A SLAP 1 lesion, they're just usually debrided. SLAP 2 lesions are debrided and arthroscopically repaired with sutures. SLAP lesions 3 and 4, if any bucket handle fragments are there, then they're excised. So then you'll have physical therapy post-surgery. So for the first 2 to 3 weeks post-op, the patient is going to be immobilized in a sling and internal rotation. So they're going to do pendulums and elbow range of motion. At 4 weeks, we're going to start with active assisted range of motion and passive shoulder motions. External rotation is limited to 30 degrees at this time. At 8 weeks post-op, resistance exercises are introduced, and then we're also going to especially work on scapula strengthening. And then at 6 months, the patient can generally return to sport or whatever activity they were doing prior to the injury.
So if the patient does not get surgery and they just go straight with conservative treatment, the main thing you want to do is address stability before mobility. You want to strengthen the scapular stabilizers and pain-free ranges. It's very crucial to restore normal scapulothoracic motion. You also want to strengthen the rotator cuff muscles that are surrounding the scapula and shoulder, and dynamic stabilization exercises of the glenohumeral joint are necessary. There's also going to be some neuromuscular control, and then stretching to improve range of motion to prevent stiffness in the shoulder. So the primary goal of non-operative treatment is to reduce the pain, improve motion, and restore strength of the patient.
So we're going to talk about prognosis now. As I said earlier, conservative management of SLAP lesions is often unsuccessful. Type 1 SLAP lesions can occasionally be successfully managed non-operatively. Approximately 90% of patients demonstrate good or excellent results at the short or intermediate follow-up post-SLAP lesion repair. So in a study that evaluated 34 patients, approximately 33 months after surgical repair of type 2 SLAP lesions, the overall results were good, with 91% returning to pre-injury shoulder function. The main differences in this study were seen between the patients who participated in different types of sports.
So the outcome measures for a SLAP lesion can be measured with a tool called the DASH, which stands for Disabilities of the Arm, Shoulder, and Hand. There's also a shorter version of the DASH called the Quick Dash, but the DASH is a 30-item self-report questionnaire, and it just measures physical function and symptoms in people with any musculoskeletal disorders of the upper limb. And it just provides a common tool for all clinicians to use across the span of practice. Some values for the reliability of the DASH are shown in this chart below. There's no MCID value for the actual DASH, but the Quick Dash has an 8% difference, and then the minimal detectable change for the DASH is 12.75% to 17.23%, and the Quick Dash has 11.2% for MDC.